Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! Hello again, listeners, and welcome back. On today's episode, we will discuss a recently published paper in the journal with the following title: Diagnostic Performance of MRI for Detection of Pulmonary Nodules, a Systematic Review and Meta-Analysis. This paper comes to us from our colleagues in Brazil, California, and Florida. The lead author is Dr. Cesar Campagnolo Cavion, and the senior author is Dr. Bruno Hochhegger. As stated in the title, this paper was a meta-analysis of the available studies on MRI in evaluating pulmonary nodules. 10 studies comprising about 1,300 total patients were included in the final meta-analysis. In terms of total nodules, that's about 2,000 nodules that were evaluated across all of the studies. The sensitivity and false positive rate of MRI were assessed against CT as the reference standard. Here's a brief synopsis of the results. The sensitivity of MRI for nodules 4 millimeters in size or larger was 88%. For nodules 8 millimeters or larger, the sensitivity of MRI improved to 98.5%. The false positive rate of MRI was about 12%. So compelling results. However, MRI for pulmonary nodule evaluation is certainly not a common technique. CT has historically held primacy in this regard. Thus, to help us dissect these results, as well as their clinical implications, I had the privilege of speaking with the senior author of the paper, Dr. Bruno Hochhegger. Let's jump into that conversation now. Listeners, I am now pleased to be joined by Dr. Bruno Hochhegger, the senior author of our featured paper. As a reminder, the title of that featured paper is Diagnostic Performance of MRI for the Detection of Pulmonary Nodules, a Systematic Review and Meta-Analysis. Bruno, welcome onto the podcast, my friend.
Thank you very much. It's a huge pleasure.
Of course, Bruno. Once again, thanks from not just me, but the entirety of the RSNA community for the contribution to the science and for joining on the podcast. So I'm excited to explore a couple more of those topics that you brought up in the publication. That said, before we begin, let's learn a bit more about you. Where do you currently practice? What's your position? And what are your academic areas of interest?
Yeah, I'm a thoracic radiologist at the University of Florida in Gainesville, North Florida. I'm actually clinical professor and vice chair of research here. And my main interest areas are lung cancer, MRI of the chest, and interstitial lung disease.
Fantastic. And as part of lung cancer screening and interstitial lung disease, I presume CT is the kind of workhorse modality. Are y'all doing any clinical MRI for lung imaging or for lung cancer detection?
Yeah, we have a database here with around 3,000 MRIs of the chest, but most of cases are still related to intestinal disease and vascular disease. For lung parenchyma, we just are developing some research studies, prospective research studies, trying to apply like xenon MRI in ILD, assessment of inflammatory changes in ILD, and also pulmonary nodule detection and characterization of pulmonary nodules. In pulmonary nodules, we are using more for diffusion studies of these nodules that are mainly to characterize benign versus malignant nodule, but it's not yet like the main form to assess these. We are still using much more PET than MRI to this assessment.
I want to go into that idea a little bit more as to why MRI has not achieved that degree of primacy in evaluation of pulmonary nodules compared to CT and PET. Could you describe maybe some of the more fundamental ideas behind why historically MRI has not achieved that degree of, we'll say, popularity for nodule identification?
Yeah, I think we have sufficiently data for more than 10 years to show that MRI is very valuable for First one, characterization of pulmonary nodules, benign versus malignant, and more recently for detection. But I think for me, the biggest problem is the heterogeneity of manufacturers that brings some manufacturers are pretty easy to perform. Most of them are not so easy. If you have MRI for more than 10 years, it's pretty difficult to adapt in most of the manufacturers. Then this brings a lot of complexity for performing chest MRI. I did some part of my training in Heidelberg that the guys and Dr. Coucher and be there developed the first steps of MRI. And when you are like involved in this field, is much more easy to develop. But the problem that I saw that most of radiologists and also chest radiologists has some like concern about MRI because this huge variability in results. If you get MRI that is performed in a center that would never perform MRI, the results will not be so good. And in the opposite side, CT and PET CT are very, very reproducible. Then it's much more easy to have the same results with different brands of CTs and PET CTs than with the MRI. And there's a very classical editorial from Journal of Thoracic Imaging now that have more than 10 years old. Why you are not using more MRI? And I think the main conclusion is that we need to like enter in this field as chest radiologists. The problem is that all the chest and thoracic, cardiothoracic radiologists are busy nowadays, and it's pretty difficult to enter in this new field that is very complicated. We need a lot of work with techs, with brands, with new sequences, and everyone is with a ton of lung cancer screening in your side needed to be reported, and it's very difficult. But I think it will be the next step. If you look for abdominal MRI, like in early 90s, early 2000s, it's like us now. Like 20, 30 years ago, abdominal MRI is like a second line of investigation and you use much more CT. But nowadays we know that this bore MRI grows a lot, and in a lot of indications, it's in the first line of investigations for patients. Then I think the future of chest MRI is this, but again, it's pretty difficult because mainly the heterogeneity of the brands and developments, and the chest radiology need to be more trained in these.
So, Bruno, I want to dissect that a little bit more. Certainly, the education in chest MRI has been focused primarily around, as you suggested, mediastinal and vascular imaging. There's not a tremendous amount of education because it's really concentrated in very few centers that do lung MR specifically. But you mentioned reproducibility across sites. Is that related to differences in field strength, differences in vendors? Is it related to differences in pulse sequence selection, or is it all of those things?
Yeah, I think is a mix of all of these things. One problem that we solve with MRI is not just for chest, is that every manufacturer build one sequence with a new name and almost are the same, but we need like dictionary to know what is each one in each brand. Then this bring a lot of complexity. It's not like a T2 gradient 2 millimeters. No, we have a ton of different names, complex names that bring much more difficult to educational aspect of MRI. And also, the development of MRI for chest grow a lot in the last 10, 20 years. Like now with UTE, ultra short T echo, we have like almost the same resolution that we have with CT. That is a huge step for us because to convince the surgeons and the chest physicians that MRI could be the same accuracy of CT, when you show one very morphological HRCT and you show like MRI that is just bright or not bright, is pretty difficult. Nowadays, with the UTE, we bring like more morphological aspect for MRI that I think is the last step that we need to put MRI in the clinical practice.
Okay, great. Before we dive into the paper itself, I want to perhaps approach a response to your answer with a philosophical question. So, say we do have very robust, homogeneous, ultra short TE pulse sequences across the country, and we can really get high fidelity images of the lungs. Why consider MRI altogether for pulmonary nodule detection if we have CT? What is it adding?
Yeah, I think the first thing, and it was demonstrated by a paper like 5 years ago for the group of Heidelberg, including Jürgen there, is that MRI could be more cost effective, especially for lung cancer screening. Why? Because everyone thinks, why this guy is bringing a very expensive method if you have a very cheap CT here, easy to put? No, because MRI will not detect very small and calcified nodules that sometimes could be very helpful for us because the false positives in CTs are a huge problem in oncological and lung cancer screening. Then this aspect, it's pretty important to reduce the false positives that we have with lung cancer screening or oncological patients with detection of metastatic disease. Then MRI, if you put these in a cost-effective analysis, could be cheaper. And obviously, the second step is no radiation method. I know that this old guy, like 75, one CT of chest will not kill anyone. But it's very important to know that a young guy with a neurofibroma that need, or with a lymphoma, with 70 or 15-year-old, it's pretty important to reduce the radiation. That MRI could bring these things. But I think the most important thing is try to find the nodules that are real important, because we have one method that's wonderful, that's CT, but we detect a ton of nodules. There's one classical phrase from Teresa McLeod that the guy that do not have a nodule do not live, because most of patients will have one small nodule. And in my view, when radiologists realize that MRI will have less nodule detection and it will be much more easier to report, maybe we will start to put more MRI in our clinical practice.
I think you're speaking directly into the hearts and ears of many thoracic imagers out there who are plagued by the high sensitivity and super low specificity of chest CT imaging for nodule identification. So I have so many more questions about it, but I do want to bring in some ideas behind the publication, the feature publication for this podcast. As a review for our listeners, this was a meta-analysis, and its main focus was to evaluate the sensitivity and the false positive rate, if you will, of MRI for nodule detection with the comparison of CT as a reference standard. So there were about 500 studies that were initially included in the screening, but 10 studies were finally included in the meta-analysis. Bruno, can you help us go through some of the main results from that meta-analysis and the implications for our practice?
Yeah, I think the main result of our meta-analysis is that for nodule less than 10 millimeters, we still have a good accuracy. The sensitivity of MRI for nodules 4 millimeter or larger is 87%, and the sensitivity for nodules larger than 8 millimeters was 98%. Then it's pretty good sensitivity in detection. And which nodule will miss most of case? Will miss the homogeneously calcified nodules, because you cannot detect most of them in MRIs, and the pretty small nodules. Then these results bring to us that in this meta-analysis that include all the heterogeneity of manufacturers and brands that we previously discussed, we still could achieve a good result and a good sensitivity and a good detection rates for these small nodules. And I think this is the important thing for a specific clinical setting. And we created meta-analysis mainly because we have a lot of patients that are doing staging of abdominal MRI for pancreatic cancer or renal cancer doing MRI, and this patient need to schedule other time in CT to do a CT of staging. Then the main question that we bring here was It's MRI enough to detect these small nodules that we are looking for? And the main result for us was a pleasure to see that also getting all the files of MRI that you get different magnet strain, different sequences, old and new sequences, and mix these together, we still have a good enough detection rate for these small nodules. And I think it is the most important. Obviously, that you have a state, if you have a state of art 3 Tesla with UTE, you have better results. And also we show these. We have some papers that use UTE with a sensitivity going to near 99% for nodules, more than 8 millimeters, and more than 95 in nodules, more than 4 millimeters. But it's pretty important to know that also with a normal 1.5 Tesla MRI, we could also have good enough results to have one shot study, one assessment for these patients, all with MRI, and don't need to schedule this patient 2 or 3 times. And if you look at heterogeneity of the results are in some aspects a little bit high, mainly because these we have studies that include MRIs from 12, 30 years old, and studies that include MRI from 1 year old with very state of art sequences.
Well, I think that point is a important one because the clinical reality is that most centers across at least the United States, if not the world, are going to have heterogeneous magnets. Even in the same institution, you may have a state of the art 3 Tesla magnet, but at the same time, you may have a dinosaur 1.5 magnet that's sitting in the back office. That's still doing a lot of work. Um, in that regard, I suspect that this sensitivity that you've described altogether, as well as the scanner specific or site specific sensitivities, is very helpful for our community to understand that this is clinically acceptable. And that's what I'm gathering from this, right, Bruno? This is a clinically acceptable sensitivity for identification of meaningful nodules, both for lung cancer screening as well as cancer detection for metastatic disease workups. Is that accurate?
Yeah, this acceptable depends of your clinicians and the departments that work with you. But the feeling that we have here is that these nodules that are pretty small, like around zero point 0.4, zero point 0.5 centimeters, are more a problem than advantage in detection for most of clinicians. When you have a nodule, and TNM described this, more than 8 millimeters, you need to have the comprovation of everything. If it's metastatic or not. If it's less than 8 millimeter, I'm talking just about oncological patient. That I think is the main file that we should develop MRI nowadays, because these lung cancer screening, it's interesting, it's cheaper, but it's impossible to have enough magnets in the near future. But for oncological patients, I think it's a reality for everyone. Everyone is doing MRI to staging liver, kidney, pancreatic cancers. Then develop one chest protocol to do one shot study will be very good for patients, very good for the departments. Then, if you could detect very well nodules with more than zero point 0.5 and especially more than zero point 0.8, it's pretty helpful for the clinicians. And if MRI, you could do this. And the second thing that we not discuss here in this, but we have a prior meta-analysis published in radiology too, that shows that diffusion is the same than PET-CT in the accuracy of characterization of pulmonary nodules. Then you could do the detection and characterization of these nodules. That will be very, very interesting for the clinicians to have one shot assessment of this patient with detection and characterization of these nodules.
I wanted to save this part of the discussion for later, but this is a natural segue now. Um, as you had mentioned, there's heterogeneity across the included studies in the meta analysis in terms of what pulse sequences were performed for, let's say, nodule detection at MRI. Can you describe perhaps the impact of the most common pulse sequences on the sensitivity analysis, and what you would prefer as the best pulse sequences to perform for, let's say, oncologic staging, because that seems to be the most relevant for this particular application.
Yeah, we try to do this and dividing each sequence, but we realize one thing, that most important than sequence is the slice thickness. Then, if you saw I think it's table 3 of our paper, we divide the MRI technique in smaller than 1.25 millimeters and thicker than 1.25 millimeters. Then, if you have a sequence with slice thickness of less than 1.25 millimeters, that usually is UTE, you increase a lot your sensitivity to around 93% if you include all the nodules. If you get sequences with more than 1.25 millimeters that are a little bit more old sequences, you decrease your sensitivity for 83%. Then I think the most important is nowadays, and what change the accuracy of MRI nowadays is the UTE sequences that allow us to perform very thin slice thickness in patients with around 1 millimeter with the same resolution of CT. That is pretty helpful. Then if you have a UTE, most of them are UTE. You have other brands that not use real UTE, but also have one less than 1.25 millimeters slice thickness. These have a huge difference for patients' nodule detection.
Excellent. So my takeaway there is thinner slices is the most important contributor to sensitivity in terms of nodule identification. You had mentioned diffusion weighted pulse sequences. Do you think that's a must, if you will?
Yeah, I think the future of nodule study in MRI, it's one set of sequence for detection that I really believe in UTE, and one set of sequence for nodule characterization that will be T2 weighted sequences and diffusion. Then diffusion is the next step, because imagine if all of us have one CT scanner that could also do a PET with just 5 minutes of equipment without any other problem. It would be a huge advantage. And MRI have this. You have the detection part and you have the characterization part. And with the characterization, you could have the same accuracy of PET and tell the clinician if it is benign or malignant nodule. Then I think it's a pretty good application for one shot study.
Fascinating. Okay, great. I think that helps us understand what the potential approach to a robust clinical MR program would be for oncologic workup of the chest. Let's talk about another component of the analysis from the meta analysis, which was about false positive nodules per patient. Can you clarify what that statement means, the false positive nodules per patient? Is this identifying nodules that were seen on MRI that were not present on the reference CT?
Yeah, this could happen in MRI, especially for the old sequences that you have gated, respiratory gated. Sometimes you could identify some small false positives, nodules in this kind of patients. Then it's happening, but usually it's very small, a month of these nodules. And when you compare with CT and you use like malignant as references, like how many false positives you have in CT, how many false positives you have in MRI, the CT have a huge higher
Oh, yeah.
number of false positives, because the CT will detect very small nodules that less than 3 millimeters. MRI also with UTE is pretty difficult. No? The unique setting that you could detect like very teeny small nodules is like a miliary pattern. Then you change all the signal intensity of the lung parenchyma, and then you detect. But for like solitary 2-3 millimeters pulmonary nodules in MRI, it's almost impossible nowadays. Sometimes you could detect, but it's not the objective of the method right now.
Got it. Want to talk about MRI for specific scenario. You already mentioned, much to the happiness of us thoracic radiologists, the relatively low sensitivity of MR for very small nodules, which is great. Now, we want to improve the specificity of this technique as much as possible. You mentioned homogeneous calcification as usually not identifiable in MRI. That's great as well because these are often benign nodules, oftentimes calcified granulomas. What about subsolid nodules, ground glass, and part solid nodules?
Yeah, this is still a limitation of MRI for pure ground glass nodules. We know that the index of detection it's around 60 to 70%, but for lung cancer screening, especially that this is very common, we know that we will not have any change in management of patients with nodules less than 3 centimeters that are pure ground glass. For solid component in these patients, if the solid component have more than 5 millimeters, that is the most important part of solid component. MRI will have a good agreement in detection, a good detection rate. Then again, MRI will detect what it's important. It's large semi-solid pulmonary nodules or pure ground glass pulmonary nodules, and also you detect the solid component of these nodules. Obviously, that if you have a solid component of 2-3 millimeters, will be a challenge for MRI. But we know that these solid components are not so important, and you have this magic threshold of 5 millimeters. And it's good for MRI because more than 5 millimeters will detect most of these nodules with a detection rate of more than 90% in all different kind of scanners.
Okay. So some broad strokes takeaways for me here thus far. At usually at 3 Tesla, but including at 1.5 Tesla, UTE thin slice imaging is excellent at identification of nodules of all sizes, particularly solid nodules larger than 8 millimeters in size, as well as larger than 4. It can do a great job of identifying those clinically meaningful nodules, and the suspected most important clinical application would be for oncologic staging of malignancies, say outside of the thorax. The included studies, to my understanding, is they had magnets at 1.5 and 3 Tesla field strengths. There, however, has been a lot of popularity recently in lower field strength magnets. Could you speak a bit to the challenges and potential advantages for nodule detection at lower field strengths?
Yeah, nowadays we have some studies that we do not include in these meta-analyses that are using less than zero point 0.5 Tesla to detect to assessment lung parenchyma with good enough results. Uh, but the problem that I saw in these low-field magnets, it's the clinical practice because MRI of the chest will not be the first step in assessment of chest disease, or you not have enough patients to study an entire day of a magnet. Then we still need to do a lot of brain, a lot of knee, a lot of spine, a lot of abdominal MRI. And these low field MRIs are not state of art for the rest. For MRI of the chest, we still have very good results for lung parenchyma nodule detection. Diffusion is not so good. That I think is a huge problem because detection is one thing, but I think the real value of MRI will be also have the diffusion in the same study, a quality diffusion. Then I think it's other problem that need to be solved in low field MRIs. But I think it's one very interesting area of research. We have a recent paper for Nature that use one 0.05 Tesla, having very subtle results, and you don't need a huge magnet for have 0.05 Tesla to do images. And I think this is one way for research, but it's not near the clinical practice as you have 1.5 and 3 Tesla to assessment. And nowadays, 3 Tesla is starting to be the standard of the clinical practice. And one thing that is like brings some happiness for us is that in the past we always think that 1.5 Tesla are better than 3 Tesla to assess lung parenchyma and pulmonary nodules. But with recent studies, we describe that we increase the sensitivity of MRI in detection of pulmonary nodules in 3 Tesla. Because there is a huge discussion because air have some susceptibility magnet effects that could cause problem at the 3 Tesla scanners. But nowadays we know that the 3 Tesla it's more accurate than 1.5 Tesla in nodule detection and MRI. Then I think the future is in the scanners that we have ready to clinical practice and start to doing this MRI of the chest in what we had. But I really believe that low field scanners will be very helpful in the future because they are cheaper, they are easy to perform, they do not need so many care with the environment around, and I think it could be very helpful in the future for this detection.
Excellent. Bruno, you're an expert in the field of MRI in general and MRI for the thorax specifically. You're obviously a proponent of thoracic MRI, particularly for oncologic staging. Do you need to see more data before pulling this out into the clinical prime time? And if not, what's stopping us from doing more of this?
Yeah. I think we don't need more data to put this in the clinical practice. I think we need more dedication of all radiologists in understand and set up the sequences. And you told for us one thing that's very important. Most of departments do not have just one brand, one kind of scanners. You have 3, 4, 5, 6 kind of scanners. And this is a problem of MRI. You need some dedication for each one of these scanners. But again, after you start to do these things, it's much more easy and we start to develop this very well. And I think the data will have more than 10 years of very strong data showing that we could start to do MRI of the chest right now. The real problem is the reproducibility in our departments. And for these, we need much more dedication of chest and thoracic radiologists to start to doing these. And I think in the future will be the MRI assessment of specifically for oncological patients and for classifications of pulmonary nodules with diffusion. The unique problem that I saw is that if you get our meta-analysis, you see that more than 95% of data are from outside US, especially Japan and Europe. US do not have like a culture yet of development of MRI because we are shorter, I think, in magnets and chest radiologists in everything. But I think we need to start to work in these and try to develop these because certainly this is the future of thoracic imaging. And it's ready to go anytime just with a small dedication of our chest radiologists.
Awesome, Bruno. Very inspiring, especially as a cardiothoracic imager myself. It's an exciting field to be a part of, and it's something I would certainly like to explore in my own clinical practice. Do you have any final thoughts before we conclude our conversation?
I think one thing that's pretty important for everyone that's listening these is that MRI it's a wonderful tool. It's a new form of thinking for chest radiologists. But when you start to using these, you see that's much more easy, and you could help a lot our patients with a method that it's widespread of radiology and in chest is just becoming. And there's also opportunity for everyone that would like to do research because we are in the starting area of MRI of the chest in the US, and we have a strong amount of opportunities here to development of research and specific applications of MRI.
Fantastic. Bruno, this conversation, but for me, for our listeners, has been super insightful. Thanks for providing your insight on not just the paper, but the field of MRI in the thorax, generally speaking. So kudos and thank you very much for coming on to the podcast. I really, really appreciate it.
Thank you very much for the invitation. And again, we have a wonderful new area with MRI. Thank you very much.
Yeah, excited to pull forward in it with you in the field of cardiothoracic imaging. From the journal, thank you. For the listeners out there, thank you as always for tuning into the podcast. Remember, if you like what you hear from us, please rate, review, and subscribe to us. That helps others out there interested in this content find us. This is the Radiology Cardiothoracic Imaging Journal. We will see you next time.